All right, this is chapter 3, recording 2. We're picking back up with confidentiality. So any information that we get as a healthcare provider should remain confidential, meaning that those that don't need to be in the know should not be in the know. If it's to do with continuing medical care, sharing with police officers or other emergency personnel on the scene because it will help the patient or help them do their job better, absolutely letting the hospital know as we hand off the patient. Those are all acceptable instances. Sharing with insurance for insurance payment purposes is acceptable. However, just going to a friend or family member going, hey, guess who I took care of and guess what was wrong with them. That's not okay. So this has become a huge thing over the last 10 years. We call it HIPAA. And you typically cannot disclose a person's protected health information unless they sign a release or you get a legal subpoena from the judicial system that says, hey, we got to talk about this, or if it's needed by billing. So HIPAA, the Health Insurance Portability and Accountability Act of 1996, definitely has a huge section on patient privacy, strengthens privacy laws that were already in place. There's a group of information that is considered to be protected health information that you cannot share. These things include patient identifiers, so names, birth dates, addresses, specific diagnoses. You can't share it. I know that as a healthcare professional, especially pre-hospital healthcare professional, we see some pretty messed up stuff. We see some pretty questionable things, some entertaining things. But think if that were you or your family member. Would you want them going and telling Joe Schmo on the street that they saw you and that this is what happened? One of the things that I tell my kids, my stepkids, when they step out the door is make good choices. Don't do anything you wouldn't want to explain to the paramedics. And oftentimes I find that the rest of society does not follow that whatsoever. But they still have the right to privacy. Advanced directives is another thing that we run into quite frequently on the job. This specifies treatment that a patient wishes to receive or not receive if they're unconscious or unable to make their own decisions. This was always something that I thought about growing up as something that old people in nursing homes had. However, as I've grown, this is actually a more abundant thought than I originally thought it was. I've had an advanced directive since I was 18. And I know that a lot of healthcare professionals do encourage their patients to fill out advanced directives in the event that something happens. It definitely takes a lot of pressure off of family members because instead of making those massive healthcare decisions for their loved one's already made the decision, has already written it down in a legal form, and they don't have to feel the pressure of trying to make those decisions. One sort of order is a do not resuscitate or DNR order. It's an advanced directives that says, hey, if in the event that I go into cardiac arrest, I do not wish to be resuscitated. This doesn't mean don't treat me at all. Somebody goes unconscious, there's something wrong with their heart, cardiac arrest is imminent. That doesn't mean you can't give them oxygen. That doesn't mean that myself as a paramedic can't give them pain meds or something to make them more comfortable. And they even go to the point of specifying what you can and can't do. You can give me oxygen, yes, but do not intubate me or put a tube down my throat. do not give me CPR. However, give me cardiac medications. And they go through a process that they have to be informed as to what their decision means, and they sign it. Even if the patient is a DNR, you still have the ability through non-medical means to make them more comfortable. Positioning is huge. Putting a blanket on, putting a pillow on, kind of taking that extra little step that, hey, you know what, if this was me, this would be nice. Other advanced directives, a living will and a healthcare directive is another type. Some patients have named surrogates or power of attorneys to make decisions for them. The other term is healthcare proxy. And they say, you know, even if I don't have a true living will or an advanced directive, I know that this person will make the proper decisions for me. And this is why I ended up creating a living will or an advanced directive when I was 18, because I was made a proxy for somebody and then had to make decisions that were very tough to make. Sometimes where this becomes a problem, terminal nursing home placements, meaning they know that they're going to the nursing home and not coming back out of it. Hospice, home health programs. It's very often that we are faced with an advanced directive. The thing that's hard with it is when they say, no, they have an advanced directive, but they can't provide proof. If we are without the actual physical paperwork, we have to still provide adequate care, known as life-saving measures, to that patient until the paperwork is presented. A tattoo across the chest saying DNR is not sufficient. People have done that. People will continue to do that. It doesn't count. We still have to provide care to them. Sometimes you may be presented with a DNR and it may just feel wrong. I know, the couple of times that we were faced with it, it was terminal children, the times that it bugged me, either for congenital abnormalities or cancer, something like that. And you feel obligated to treat them because you were called there. They called 911, but really what they were hoping for was to make that loved one as comfortable as possible, not to save them. And just sitting there watching the vitals continue to decrease can be very overwhelming. But again, the patient's wishes or their power of attorney's wishes, all you're doing is honoring them. You're not making those decisions for them. In our line of work, as discussed before, we will come across death. However, we as a pre-hospital care provider cannot determine cause of death, and we legally cannot call time of death. There are presumptive signs of death that we know, but the general rule is that if a body is still warm, you initiate emergency medical care. A person is not dead until they are warm and dead. So in the case of hypothermia, somebody falls through the ice into the water. It's amazing what cold can do to a body and how it can sustain it for longer than imaginable. So if you have a cold water or cold situation, hypothermic, hypo being less than thermos temperature, so low temperature type situation, they're not dead until they are at least warm and dead. So keep that in But unresponsive to painful stimuli, some people can be literally that unconscious that they don't respond to painful stimuli, but often painful is kind of our bottom line for consciousness. If they have a lack of carotid pulse or a heartbeat, carotid pulse is called a central pulse. The ones in your wrists are called peripheral. You can still have a carotid pulse. You can still have central circulation, even if you don't have a pulse in your wrist. What your body will do is it actually shunts blood into the core to keep you alive. So even though you're getting a little bit of blood flow out to your appendages, it's not going to be enough to produce that palpable or touchable pulse. And so if they don't have a central pulse or central circulation, that's not something that you typically can recover from. Absence of breath sounds. There are some situations where you don't get breath sounds, but in combination with a couple of these other things, not great. No deep tendon or corneal reflexes. So corneal reflexes is in your eye. If you shine a light into just one of the eyes, both will constrict at the same time. If you pull the light away and it gets darker, both will dilate or get bigger at the same time. If that is lost, that means that the brain isn't utilizing reflexes. The absence of any eye movement, no systolic blood pressure, profound cyanosis. Cyanosis is a bluish to purplish discoloring of the skin because of lack of oxygen within the blood. If that's more than just the fingertips, more than just the lips, kind of starting to spread throughout the body, that's a presumptive sign of death. And then lowered or decreased body temperature as well. Not in the presence of like severe hypothermic conditions. Other definitive signs of death, if there is decapitation, typically don't need to do CPR on somebody that's missing a head. And a lot of times there'll be protocols that say, hey, if these obvious signs of death exist, you don't have to provide life-saving measures. Dependent lividity, which is the picture that you're being shown on the screen. What happens when somebody dies is that all of their blood vessels relax and they no longer are moving blood. Capillaries become very, very porous and leaky, and your blood ends up running to the lowest point of gravity on the body. For this person, happens to be the back. And so it causes a severe bruising or discoloring of the skin on that lowest point. Rigor mortis is a stiffening of the muscles caused by chemical changes within the muscle tissues. This occurs between 2 and 12 hours after death on average. There's a lot of different factors that can affect when rigor mortis sets in and how long it lasts. If you have putrefaction or decomposition of body tissues, can occur anywhere between 40 and 96 hours after death. Again, depends on some external conditions, but on average, that's not something you're going to work through. Medical examiner cases, this all depends on the nature of the call, the scene of death. We often have to call a coroner to come out, and they want us to leave all of our treatments in place, and we explain what we found, what's the known history of the patient, what we did, and what the outcome was. In most states, the medical examiner must be notified on specific calls, so dead on arrival or dead on scene, death without previous medical care or when the physician is unable to state a cause of death, suicide, particularly violent deaths, poisoning either known or suspected, death from accidents, and then anything that is suspicion of a criminal act. Oftentimes, I mean, we've called into the coroner and they call back and want to know the circumstances, and they're like, nope, this is not my case, go ahead and take them. Some ambulance services provide transport to funeral homes. The funeral home responds and picks up the deceased. If emergency care has been initiated on somebody, make sure you keep thorough notes of what was done, what was found, what you moved. And sometimes this is just a mental note, just to take a quick glance around before you start treating the patient. And then if you don't initiate care, same thing. What you saw, what you found, why you didn't initiate care. All right, this will be recording number 2, and we'll continue with recording number 3.